Local programming on KRWG Public Media made possible in part by viewers like you. Thank you.
Hello and welcome to Fronteras, a Changing America. I'm Anthony Moreno. A new report says that COVID-19 vaccination hesitancy is highest among Hispanic and Black adults in the U.S. Here to tell us more about this NMSU study is Jagdish Khubchandani, a professor of public health sciences at NMSU. He co-authored this study. Dr. Khubchandani has a doctorate in clinical medicine from India, a master's in public health from Western Kentucky University, and a PhD in health education and epidemiology from the University of Toledo. Dr. Khubchandani, thank you so much for joining us.
You're welcome. Thanks for having me.
Now, I'd like to hear more about this study, but really first, just what interested you about this topic?
Yeah, so, we have a team publishing a series of papers on vaccine hesitancy and looking at vaccine hesitancy around the world. So we wanted to dive deep into different types of populations. Our first study, which was a national American study published in December, looked at Americans nationwide, and we found that Hispanics had the highest hesitancy and African Americans. So we really wanted to collect all the evidence on these two populations and look at why they are hesitant to vaccines. And finally, we had a sample of 100,000 people, and we looked at vaccine hesitancy in those people. And we find that African Americans have the highest hesitancy and Hispanics are the second in line compared to the national average. And we wanted to also look at the reasons, but it doesn't seem like there could be one reason. It's a multifactorial problem, a unique type of problem that we are facing right now.
Now, one of the findings of your study was that out of overall COVID-19 vaccination hesitancy among Americans, overall adults, it was 26.3%, Hispanic adults 30.2%, and African American adults 41.6%. Now, you mentioned this could be a multiple reasons why that folks are hesitant to get the vaccine, but when we're dealing with Hispanic and African American adults in the U.S., what are some of those findings? Let's dive into it a little bit more regarding the demographics and what were you finding there?
Yeah, I think the part of the problem comes before the pandemic. Hispanics and African Americans did not have the highest awareness of health systems, the regular interaction with healthcare providers, a lot of medical mistrust and racism, and they have been affected by injustices in the past, and that leaves some skepticism in their mind. On top of that, during the pandemic, there has been another problem that we call infodemic, that there has been a lot of rumors, misperception, and myths. And I acknowledge those because people can be concerned. The vaccine was developed in a speedy time, and we don't know the long-term results of the vaccine. But now they appear to be safe. But initially, African Americans and Hispanics seem to be more vulnerable to misinformation and rumors, and they didn't have the ability to dive deeper and dissect information, go to a healthcare provider and ask them about what these vaccines could do. And so it's a dual problem. Part comes from before the pandemic, and now in the pandemic, there's a lot of misinformation that's floating around. We also find that females who are younger, lower income, frontline, low wage earners are the ones who are also most hesitant because they are also concerned about taking care of a family. Sometimes the rumors of infertility affect them. And then there's historical injustices and mistrust that exists.
Okay, now you named multiple reasons why this could be, but could you kind of let us know a little bit about how you discovered this? What sort of metrics did you use?
So we collected evidence nationwide. Any type of study that has been done in the United States, any piece of evidence that has been collected in the United States in the past 3 months, we collated all that evidence, then pooled the number of people in each study. And that's why our sample is the biggest, 100,000 people. And then finally, we read all the observations across the United States to pick up factors that could affect vaccine hesitancy. And so it was I call our research is evidence synthesis. that it's not just one study that shows vaccine hesitancy in Blacks and Hispanics. It's multiple studies across 100,000 people. So really, we dumped every piece of evidence that exists to see if it's really a true finding or it's just one-off.
Now, you mentioned misinformation being one of the major factors that could be contributing to this. Now, what sort of evidence did you find dealing with misinformation that really affected these groups?
Yeah, there's a bunch of things that have been floating around. One, I think there's deliberate attempts to derail the American vaccination campaign by certain groups of people. Then there's people on social media who propagate myths. Sometimes the media, the traditional media, also has the tendency to pick up on one side effect, one case of death, which has happened with Johnson and Johnson vaccine and others, 7 million doses administered. But we have to pick on those 7 cases that were having blood clots. That unfortunately, the way it travels to African Americans and Hispanics, it's a different story altogether. And then finally, there's the impression of historical injustice, medical mistrust in the community, not being able to see a regular healthcare provider, further accentuates the problem.
Now, you mentioned by the time the news and information gets to the communities, I mean, what are you saying? Is there a lack of access to information regarding what is happening with the vaccines?
Yeah, there's selective negative news traveling, and then there's misinformation being propagated. Sometimes the way I consume news is different from other people consuming it. For me, 7 cases out of 7 million vaccinations administered is much better than going out to get a vaccine and being killed in a car crash. So I have the ability to understand statistically where are my chances of being safer or dying sooner. But for some communities, it's the way the media has portrayed things, and then it goes twisted and tweaked into communities. That travel of information is problematic, especially when you are skeptical and you have some amount of medical mistrust that exists from centuries.
Now, you mentioned centuries. You're talking about centuries of discrimination and racism?
Yeah, like, the Tuskegee syphilis experiment, it's gone and past and done, but still, when people know about it, they inherently start misbelieving, or they don't have the faith in a traditional white male doctor that an African American male should have. It's a part of it is because of the history. A part it exists even today.
What about access and access to health care? How does that affect this group?
The lack of access to healthcare is a big factor here, because if I'm not regularly visiting a doctor or a nurse or a provider, that bridge that had to be made was not made. And so if I'm distant from an entity like a doctor, I really become skeptical, or I'm just not used to that conversation. And so that has affected vaccine hesitancy as well, that I don't have the access to go and ask someone who's qualified to tell me reliable information. And I just watch a bunch of people talking, and that's my source of information, which oftentimes is not correct. So access does play a role.
Now, when you're talking about the Hispanic community, what were some of the things that really stood out with that community that may not have affected other communities?
I think in Hispanic communities, it's a lot of lower education problem, lower digital literacy, health literacy, a huge digital divide. For example, in the border area, it could be challenges with immigration issues. If I get registered for a vaccine, will I be kicked out of the country? Will I be tracked? And so that group happens to be slightly different with a lower vaccine hesitancy than Blacks, but still multiple challenges, especially with young females then when they hear about infertility type side effects. For a female, having a child is a lifetime privilege. And if you just tell them once that there's a possibility of infertility, then religion comes into play, family influences come into play, and it gets difficult to disentangle that complex web of misinformation.
What about unique factors with African Americans? I mean, is there anything that really stood out with this study that you think needs more attention?
Yeah, I think in African American populations overall, it's an extreme of the really, really old people who have known the history of Tuskegee experiment or injustices, and the really, really young populations, the frontline workers and such. So it's an extreme of population age groups that's hesitant to get a vaccine, and especially single mothers, single females. when they have to take care of a family and they cannot afford to be in the bed for 2 days to deal with the side effects or any long-term side effects, that affects their vaccine uptake tendency.
Now, we've seen access to vaccine vary when it comes to urban and rural communities. If you live in an urban community, you can get a vaccine shot just going to a baseball game in many cities, or perhaps they will even come to your house and administer the vaccine. But when we're talking about rural communities, it's very different. Now, were you able to look at that?
Yeah, rural America has a great digital divide. On top of that, they never had stable health systems in their own communities where they could walk in and get a vaccine or talk to a healthcare provider. So, one, rural America has lesser education, lower income, lower unemployment, where they could go to an employer site, get a vaccine. On top of that, we've not done a good place-based approach type of thing for vaccine uptake in the rural America. Mobile van clinics, making it easier for people to access it, not requiring a complicated registration system. It's a problem worldwide right now in many Asian countries. They have these digital apps to get vaccines, which leaves behind most of their rural populations because they have no cell phones, no smartphones.
So, how are these other countries working to solve that problem?
So I think, for example, I can talk about India. Now they have community-based volunteers trying to get to people door to door and registering them for the vaccine. Or when you go to a grocery store or get to see a doctor in a hospital, they have these volunteers who will register you. But again, you have to then hand write a note, uh, XYZ date on this time, you should come here again and get a vaccine. So it's not a constant flow of information, but they're trying their best. And I'm assuming urban India, urban Asia has a great uptake of vaccine, but rural America, rural Asia has a huge problem to deal with. And it's not that people are hesitant, it's just that people don't know what they're supposed to do.
Well, there still seems to be a little bit of confusion regarding the COVID-19 vaccine
Right,
across the globe and in the United
right.
States. People are still trying to understand what is the right vaccine, perhaps, to take. There's a lot of confusion about what may be safe. We had the FDA, the issues with the Johnson & Johnson vaccine, the halt with that vaccine while they had to figure out if it was safe. That concerned a lot of folks. So
Yeah.
with what you're seeing right now with the COVID-19 vaccine, do you think things are moving in the right direction, or do you think in Hispanic and Black American communities, is there still a major lag?
And there still seems to be a major lag. I think we're doing fine nationwide. Almost 10 states are now hitting 70% rates for adult vaccination. But one of the challenges that I find is a huge challenge in the pandemic. We always have to be having some amount of foresight and thinking way forward. In my own studies, for me, I have to plan the next thing now for the next 5 years. But when we had a huge demand and less supply, at that time we should have planned for greater supply and lesser demand, which we failed to do. And now we are scrambling around looking at who's not taking a vaccine. Can we give a lottery? Can we give a giveaway? That should have been done in December to prepare our local communities, local leaders, have some place-based approaches, find trusted voices. And I think that's where we failed, and the last mile would become extremely difficult due to the lack of preparedness in these communities.
Now, I mean, all of this is in regards to this is a once in 100-year event dealing with this pandemic globally, but a high official with the Centers for Disease Control already said that the United States is not ready for another pandemic. When you hear things like that, what does that make you think in regards to the research that you know so far and what the United States is capable of responding to right now in regards to this pandemic?
Yeah, it doesn't surprise me worldwide when leaders and agencies say we are not prepared. I think the first problem is that we don't even know what preparedness means. I wrote in April 2020 that preparedness should not be seen as a static concept. It's more dynamic. We are never fully prepared or unprepared. We are mostly underprepared. And that needs a huge amount of investment into manpower, resources, research, and development. And we have to be able to take those risks. a once in a century pandemic, but we have small epidemics emerging periodically in the last 10 years: SARS, MERS, Zika, Ebola. Even when 911 happened, almost 20% people around the nation who are in disaster management, emergency management were prepared. Health departments were prepared. 80% were not prepared. So I think our policymakers and leaders have to be having some foresight, look at new global health and global health security threats, and be able to make those decisions quickly and be bold enough to make some risk-based decisions, even if it means that you end up losing some money in the meanwhile, that you set up an office of disaster management, and for 10 years you are not making any money on it. But in the 11th year, you'll make money on it.
Now, dealing with Hispanic Americans and African Americans with vaccine hesitancy, what do you think public policy makers need to be aware of when it comes to this issue? What does your research shine light on?
Yeah, I think a couple of things. One, a bad tendency to avoid, a really, really bad tendency to avoid, is to name, label, or shame people. I have family members who are healthcare providers, don't want the vaccine. And I've never taken that approach to sound motivated and aggressive with them or challenge them that how can you not be taking a vaccine with your education and a PhD? So one, avoid any kind of motivated, aggressive messages. Then I described the 5 C's in my research, that you have to look at the 5 C's. Increase the confidence of people and calculations in favor of the vaccine, reduce constraints, and promote collective responsibility. Make it friendly for them, easy, accessible for them, and answer all questions that they have, acknowledge their hesitancy. So, we write about a bunch of strategies. I provided 8 recommendations in my research, that this is the path forward. And it's not one strategy that you throw out a bunch of lotteries and people will get vaccinated. No, it has to be multiple approaches at multiple levels. And you have to make it so easy that it's reaching out to the homes of people. And we always have to, in my field, I always take an inspiration from your field, your outreach. Phones like Apple and Samsung, why do they have such craze in the public that everyone wants it? And not for vaccines that are life-saving. So I took some lessons from marketing and media, and I put that in my research as well.
Interesting. I want to stay with vaccine hesitancy, but learn more about another research topic, another research project you were involved with, and that is vaccine hesitancy in healthcare workers. You took a look at healthcare workers across the globe. This is what's being said to be kind of the first research of its kind. You were able to survey over 76,400 healthcare workers across the globe. 22.5% were hesitant to take the COVID-19 vaccine. Now, what are the major factors with this study that you found out?
Yeah, this time I was surprised. So we again did an evidence synthesis. Any kind of evidence that existed around the world for healthcare workers on vaccine uptake, we collated it into one paper. 75,000 healthcare workers around the world, and a fifth of them did not want the vaccine. And then we dissect the findings. It's again females, the frontliners, the low income, low wage. When you see a traditional physician, a male, older doctor, those were the ones who were more likely to take the vaccine. But then you get into support staff, nursing, allied health professionals, lab technicians, who are mostly low income females. That's where the vaccine hesitancy is the highest. And again, the concerns with side effects, not being able to take a day off, or having to take care of a family, and the rumors and misinformation that float around. I also believe that healthcare workers are a part of the broader society. They're human beings and they reflect what's happening in the general society. So, as much as I'm surprised with healthcare workers not taking the vaccine, I also acknowledge that they do not have the best health behaviors, the type of education that we believe they may have, and they are a part of the broader society. I could be spending 8 hours in my office, but 16 hours I live with a family that has a certain culture and a belief system.
Now, you mentioned one of the factors was side effects. Can you kind of elaborate on that a little bit and how that may have contributed to healthcare workers being hesitant to take the COVID-19 vaccine?
Yeah, some healthcare workers have partial knowledge, so they have heard about these side effects because they look at a skewed population. Anyone who comes to a hospital is not there for entertainment. They are truly sick or having some issues. So that's the population healthcare workers look at. And then they make judgment that someone had a vaccine and then they had pain and fever. Maybe I'll have the same type of problems. But they are not looking at the hundreds and millions of people that are vaccinated around the world who are at home now able to enjoy their life as they were before the pandemic. So the exposure of healthcare workers is with a skewed sample. And then, half knowledge is not good. So they are thinking about what will happen in the long term because they know there's no long term study. So they just depend on that metric and they start making these assumptions that the vaccines could not be safe forever.
Now, they're already working in the healthcare field, but how does access play a role? Was that playing a role in any of these factors?
Yeah, healthcare workers had easier access. They were the priority groups. And so we assumed they will get vaccinated, but many could not take a day off. They were just waiting and watching. So sometimes we think the employers also have to play a bigger role. Maybe have soft mandates or some kind of protocols, which now we see nationwide and worldwide that either have a jab or a job. So it seems like very aggressive, but maybe that's the need of the hour for the next 3 months.
Now, if they're healthcare workers, many of them may have already been exposed to the virus, and some may have already contracted the virus. Did that play a role in any of these decision making?
Yeah, many of them who were infected because they were direct patient care frontliners thought that they have durable immunity for life, so they thought they didn't need the vaccine. But they have to know that the vaccine provides a longer term immunity, and the chances of being reinfected are lower down with the vaccine.
Now, looking at these studies, both of them, and looking back at them, what do you think about vaccine equity, and did that kind of play a role in a lot of this research and what your findings may have been?
Yeah, equity is a big issue. We have a strange situation in the pandemic, and I don't know if anyone is to be blamed. First of its own kind pandemic, and then we have a vaccine rolled out, then we have these eligibility things, frontline, non-frontline. I think the public was overwhelmed with the information that was floating around. And so that has further, made things more difficult for people. On top of that, the different types of eligibility, statewide challenges, issues with rollout, equity was a big issue. Again, like in popular things in the market, when a new phone is launched, there's long lines, and then the interest dies down, and we have to follow that marketing path to further improve the uptake of vaccines. Like I was just thinking about it, 50 million extra doses of vaccines are lying around in the United States. We have the potential to vaccinate most healthcare workers around the world if we ship all those vaccines everywhere in the world and show the leadership role that United States comes to play. And also those vaccines that are lying around, healthcare workers, make it easier for them. Just give them the time off that they want to take for the vaccination.
Health officials in the U.S. have cautioned people from discussing that herd immunity was a goal. They've said stop thinking about herd immunity at this point. It's just really a matter of getting as many people vaccinated as possible. Was herd immunity what some folks may have been waiting for in your research?
No, we didn't find much on that. And I think, in my view, herd immunity, I never understood the concept, though I've read a lot and I've worked in the front lines in India, door-to-door vaccination campaigns for polio. I've never been able to believe in herd immunity in real time. You always look back and say, this is when we achieved herd immunity. But in the meanwhile, we cannot have dependence on random numbers, 70, 75%. No one can actually talk about herd immunity in real time. It's all retrospective. And a better term would be herd resistance. When we have these new variants and uncertainty in global travel and migration, I don't think herd immunity is what we should look for. And the moment we start talking herd immunity, it's almost like you never win the silver, you always lose the gold. So you have 20% people around the nation not vaccinated. What if they are in one community and they're having these multiple outbreaks of COVID-19? Then your herd immunity concept around the nation fails.
Okay, now moving forward, you mentioned that you're already starting to look at some research topics a few years from now. What are some things that you've seen in this pandemic that have spurred your ideas for future research? And can you kind of give us a preview of what you possibly may be looking into next?
Yeah, so recently we did a study on how the information on COVID-19 floats around from social media and mass media, and what does it do to your brain? Is it the quality of poor information that causes you anxiety, or is it the quantity of information? So we just published on the study where we find that the quantity of information coming around is causing anxiety. You could watch bad news or fake news once in a day, and that's fine. But when you are stuck to the television for multiple hours, that causes symptoms of anxiety. So quality doesn't matter for anxiety, quantity matters. So you should have to avoid your screen time as much as you can. The next, we are looking at what happens when you know that someone died of COVID-19. Does it make you practice more prevention, or you're more likely to get a vaccine? And we find that once you know someone who has died, it really creates an impression on your mind and you're more desperate to take a vaccine. So those are two hot topics I'm pursuing right now. What is it that tells people, should I take a vaccine or not? How do they make that calculation in their mind?
Okay, well, it's very fascinating work with what you're doing. Dr. Jagdish Khubchandani, thank you so much for joining us. He is a professor of public health sciences at New Mexico State University. You can find links to his study at our website, krwg.org. Again, thank you for joining us for the program.
Thank you so much.
I want to thank you for joining us for another episode of Fronteras, a Changing America. I'm Anthony Moreno. Remember, we always want to hear your thoughts. You can email them to us at feedback@nmsu.edu. We'll see you next time.